me, GD, and after getting good inspiration from Dr. Pareek sir, Dr. Mathur sir, we decided to run a case-based discussion on diabetes, on various aspects of the diabetes. So it is the bilateral involvement of the audience and the speakers, and it will be an interactive program. And from today onwards, we shall be starting this under the aegis of RSSDI Rajasthan chapter. We have planned for every second Thursday of every month, we will be doing this case-based discussion. And today is the first case of ours. And for that, luckily, President RSSDI, Dr. Makkar sir, Dr. Sanjay Agarwal, our secretary, Dr. Pareek sir, Dr. Girish Mathur, we all are here. And we will start the proceedings. And before starting the scientific agenda, I will request Dr. Girish Mathur sir to welcome all the dignitaries and audience so that we can proceed further. Dr. Girish Mathur sir, will you start first?
Thank you, Prakash ji. Good evening, friends. It's my immense pleasure to welcome you all on behalf of RSSDI Rajasthan chapter this evening. At the outset, I extend a very warm welcome and extend my gratitude and thanks to our national leaders of RSSDI, Dr. B.M. Makkar, President RSSDI, Dr. Vasant Kumar, past President RSSDI, and Secretary General, Dr. Sanjay Agarwal, for sparing their valuable time and joining us this evening. I am grateful to all of them for always supporting us in all our academic ventures. My special thanks are due to our patron and founder chairman, RSSDI Rajasthan chapter, Dr. K K Pareek sir, who is a source of inspiration for all of us, always encouraging us for all our academic activities, guiding and supporting us. I also welcome Dr. Prakash Keswani, the project director of this academic event, for all his sincere efforts and hard work. I welcome Dr. G D Ramchandani, Secretary Rajasthan RSSDI, and the esteemed faculty of this evening, Dr. Ajay Shah, Dr. Sanjiv Maheshwari, Dr. Neeraj Lodha, Dr. Surendra Kumar, Dr. Puneet, all our friends. At RSSDI Rajasthan chapter, we are going to start two projects this year. Number one is this virtual CME on every month based on case-based discussion. And secondly, physical CMEs at various district headquarters. We'll be focusing on the small districts. Every month, we'll be doing 2 to 3 CME programs at various districts. I also take this opportunity to request all members of Rajasthan RSSDI to please register for the India-made study started by RSSDI. It's a very ambitious and very important project. I request all of you to please join in a large number. I again welcome all of you this evening, and I hope today's discussion will benefit all of us. Thank you so much. Dr. Prakash ji, please proceed for...
Thank you. Thank you, Mathur sir, for your kind words. Dr. Pareek sir, who is the motivational force behind us, starting RSSDI for last around 12 years. He has always been motivating us to conduct CMEs. I will request Dr. K K Pareek sir for the words of blessings. So we would like to hear your blessings.
Thank you, Prakash. Thank you. Good evening, friends. It's a great pleasure in welcoming all of you, especially our chief guest, Dr. B.M. Makkar, President, National RSSDI, Dr. Vasant Kumar, guest of honor, immediate past President, RSSDI, and Dr. Sanjay Agarwal, Honorary National RSSDI Secretary. I extend sincere thanks for sparing your valuable time and to grace the occasion and to be a part of this CME, this case discussion program. It's really a great and excellent initiation taken by team RSSDI Rajasthan chapter, and I extend my thanks and gratitude and to Dr. Girish Mathur, under whose leadership this excellent program of dissemination of knowledge to our clinician and postgraduates has been started. And we look forward for so many other programs which are being followed after this physical meeting at district level, peripheral level, and CME programs. I also extend sincere thanks to our project director, Dr. Prakash Keswani, who is the person who is a part of this great academic program, learning program, dissemination of knowledge, and whether it is API or RSSDI, he is the coordinator of such programs. I thank Dr. G D Ramchandani for his great efforts, for the great work he is doing as a secretary, Rajasthan chapter of RSSDI. I also extend my thanks to the learned faculty, Dr. Ajay Shah, Dr. Sanjiv Maheshwari, Dr. Neeraj Lodha, and Dr. Surendra Kumar for being present and to be part of this very important case discussion program. Friends, although COVID has given us the opportunity in so many ways, and one of the most important way which we discovered is the virtual dissemination of knowledge to our colleagues, physicians, clinicians, and postgraduates through this virtual program. It started with COVID. Before that, it was not so much popular, but with the COVID, it became very, very popular and is still being continued. I think it is one of the best way of dissemination of knowledge to all the clinicians, whether he is in the metro city or at the rural area or at the peripheral area. I think we must educate and we must talk to our colleagues, to our fraternity friends about the different aspects of whether it is a treatment for the diabetes, whether it is a guidelines for hypertension or anything. I mean, it is so easy way that we can disseminate the knowledge to everyone. And I think Team RSSDI and Rajasthan chapter of RSSDI for starting this great initiative. Thank you very much, everyone. And thank you very much for giving me this opportunity to be a part of this very important program. Thank you very much. Jai Hind.
Thank you. Thank you, sir. Thank you very much for your kind words. And we are lucky that with the start of this program, President of RSSDI, our dynamic President, Dr. B.M. Makkar is also with us. And we can see that he has done a good number of projects started, like dialogues over the obesity, over the diabetes, and a very ambitious program of the SDMH is going to be started. And he is a very good academician. And I will request Dr. B.M. Makkar sir to please say a few words to all of us. Dr. B.M. Makkar sir.
Thank you, Dr. Prakash, for very kind introduction. Good evening, friends. Respected Pareek sir, Dr. Vasant Kumar sir, great to see you after quite some time on screen. My colleagues, friends, and I can see some of my seniors also on the screen. A very good evening to everyone. I must, congratulate RSSDI Rajasthan chapter for conceiving this program of doing case discussions virtually. And this is not just one-off meeting. This is going to be every 2 weeks, what I gather from here. And this is a great initiative, and we must, give a big round of applause to Dr. Mathur and team RSSDI for this wonderful initiative. As Dr. Pareek just mentioned, we all started using technologies and learning technologies during COVID period. But once the COVID is gone, we are also forgetting that we can still use these technologies, and we are more moving towards the physical meetings. Physical meetings have their own charm, but I think there are a lot of limitations for physical meetings, and the two major, drawbacks are the cost and also the availability of time on for so many people to join at the same time, which makes very difficult to organize physical meetings. But virtual meetings, it is in fact very easy to organize. The cost is very, very low, and many more people can join. In fact, people in the far off areas, in states like you were telling, different parts of the state, everywhere person sitting in remotest corner of Rajasthan can join. In fact, people sitting outside Rajasthan can also join for a Zoom meeting. So this is the advantage of using technology, and I must congratulate RSSDI Rajasthan team for thinking about using this technology once again for dissemination of knowledge, keeping the members connected, and discuss something which is useful for everyone in clinical practice, and to build up everyone's, clinical acumen, or I would say rather polish everyone's clinical acumen, because once we are discussing, we all learn. And this learning in medical specialties is ongoing thing. Unless we keep learning, we become very stale. So I think it's a great initiative. And also another great initiative you are starting is the meetings in the small towns or small cities of Rajasthan, which is again worth appreciating. My heartiest congratulations and best wishes to team RSSDI Rajasthan. Thank you.
Thank you, sir. Thank you. After the blessings from the chief guest of today's evening, I will
Prakash,
request...
I want to interrupt also. I want to
Yes.
interrupt. I am not chief guest. I am just RSSDI member.
Yes, sir. Yes,
And
sir.
henceforth, I don't want you to put me as chief guest in any of the meetings.
Sure, sir. Sure, sir. That's
Thank
a
you.
kindness, of course, sir. Greatness. Thank you very much, sir. I will like to invite our senior member, Dr. Surendra Kumar, sir, who has been the Vice President of our society, and I will request him to please address us and say a few words to all of us.
Thank you, Dr. Prakash, for inviting me. It's a great pleasure always to be in any scientific activity done by the Rajasthan chapter. I was fortunate to be with all of you for the last couple of years, and we have always enjoyed the scientific talks. And today, under the able guidance of Dr. Pareek sir and Dr. Girish Mathur, yourself, Dr. Ramchandani, and many friends of mine, many senior faculties, all of you have embarked on a very important this step, which I'm sure will reach out to many of our doctors across Rajasthan. And also, I'm particularly happy that you are discussing more on based on the case-wise, which is important because it gives practical knowledge to the people. It also creates interest amongst the audience. So I'm happy about it. And I know you will continue to do these programs. And we are looking forward to see the very vital and then very vibrant Rajasthan chapter under the able guidance of all of you. And I wish you all the best. I look forward to listen to the able speakers rest of the time now. Thank you very much for giving me this opportunity, Dr. Prakash. Thank you.
Thank you, sir. Thanks a lot. It was very nice to hear from a fatherly figure like you. And now I will invite Dr. Sanjay Agarwal, sir, who is the Secretary of RSSDI and is working hard and has taken a very good number of steps for the progress of the RSSDI. Dr. Sanjay Agarwal, sir, I will invite you to say a few words to all of us.
I'll just keep it brief, I know, because I'm eating up on the scientific time. but I think I would like to compliment the entire leadership of Rajasthan under the able guidance of Dr. Pareek sir, GD, you, Prakash, Dr. Daria, and so many of friends who are all available over here on the screen today. I think this case-based learning is an excellent initiative for, sort of how people should implement the knowledge that they learn in clinical practice. This is one of the main objectives of RSSDI. It's not just research, but also how people do the right thing at the right time and how we can improve the lives of our patients. That's very important. So I'm going to stop here and wish you all the best. Great initiative, and look forward to be part of it in the coming days to come. So all the best. Thank you so much.
Thank you. Thank you, sir, for your nice words. Dr. GD, I will request you to please say a few words of thanks to all the dignitaries.
I think vote of thanks is to be given in the last. So, but it's already we discussed. I think it's time to start this first scientific program, and vote of thanks in the last. Probably we are already 15 minutes late. So I think you first start the scientific program, this case discussion.
So today we'll be discussing an important topic after diabetes, that is diabetic ketoacidosis. Quite frequently we find a patient who is dyspneic, who is tachypneic, and comes with the pain abdomen. And many of the times gives the history of the type 2 or type 1. And at the time of admission, you find that what is to do, what is to be done. And that is an interesting topic, common topic, and will be helpful for the practice of all of us. And for that, we have a very brilliant speaker for it. That is Dr. Ajay Shah, who is the Chief Endocrinologist of Santakwa Durlaji Memorial Hospital. And he is involved with the various scientific activities of the RSSDI as well as of the Endocrine Society of India. And our panel discussion will be carried out by Dr. Neeraj Lodha, Dr. Surendra Kumar, and Dr. Sanjiv Maheshwari. Without wasting time, I request Dr. Ajay Shah to start your case. Dr. Ajay, please.
Good evening. I hope I live up to all the expectations that have already been raised by the dignitaries. So I will first share my screen. Okay, the slides have come up?
Yes.
Okay, so dear friends, I'm going to discuss.
Now they are not visible. Now the slides are
Yeah, they will come. They will come. So I will begin with the commonest emergency, which even during the MD days, we used to treat, perhaps dreaded to treat because quite unaware of the nuances. And it's an exam question as well. And as has already been mentioned, in one way or the other, at one point of time, we will be encountering diabetic ketoacidosis. So dear friends, I would like to discuss a 19-year-old female. I would just make a disclaimer that this is a real case. When Dr. Prakash mentioned that I needed to do a case, we all have been doing fake cases for pharma company promotions. But for this meeting, I thought it is best to do a real case. So I present before all of you a 19-year-old female who presented to the emergency of my hospital 1st Feb this year. And her presenting complaints were generalized weakness for about 8 to 10 days, breathlessness for 2 to 3 days, and 1 day prior to the admission, pain, abdomen, and vomiting had started, which precipitated and necessitated the patient to seek attention. So she landed in the emergency, and on asking the detailed questions, the present history, the weakness is more general, sort of a fatigability, and the patient got tired, which the patient and the mother noted. As for the patient, for having last 7 to 10 days. And the breathlessness that was reported was present even at rest, and it was marked during the examination. It was present for last 2 to 3 days, and this breathlessness was not associated with orthopnea or nocturnal dyspnea. The pain abdomen was umbilical, non-radiating, so moderate in intensity, no relation to meals, and it was associated with vomiting, which occurred 1 day prior to the presentation. The vomiting is not bilious, it's non-projectile and associated with nausea. On direct questioning, when this history was given on direct questioning, when it was asked about increased frequency of urination, there was an affirmation, and this occurred about a week or so, right at the onset of generalized weakness. And the degree of this polyuria is that nocturia frequency is 3 to 4 per night for last 4 to 5 days. There's negative history of fever, any focal weakness in form of hemiparesis or other focal weakness. There was no cough, no chest pain, no wheeze as such. There was no prior history of diabetes mellitus, tuberculosis, drug or substance abuse. So this is the way this patient had presented into the emergency. And because of the polyuria, pain abdomen and vomiting, the emergency staff was alerted. On examination, the patient had tachycardia. She was markedly dehydrated, tachypneic. The saturation, despite being tachypneic, was 98% on room air, and there was no systemic features apart from a very mild thyromegaly, which was evident only on palpation. So 2 points in the examination. She was tachypneic, but saturation being normal, mild thyromegaly, and no abdominal signs despite pain abdomen and vomiting. So the patient So the blood sugar was ordered immediately, and this point of care blood sugar was 413. When this was done, as a reflex, we normally do blood ketone, which is done as point of care, and it was found to be 4.2 millimoles per liter, again elevated. So an ABG was done, which anyway, for any breathless patient, we do it. And she was acidotic with pH of 6.4. There was a CO2 washout probably because of the tachypnea with PaCO2 of 26, but she was not hypoxemic. PaO2 was good level. The bicarbs were undetectable on the machine that is available at our hospital. And based on these findings, we made a diagnosis of diabetic ketoacidosis. And because of a severe ketoacidosis, she required ICU admission.
Can I interrupt?
Yeah, sure.
Sir, if you do not see for the investigation and any child comes to you with a complaint of tachypnea and pain abdomen and no previous history of diabetes. Yeah. And most of the time they come into our clinic. So what we should do and how can we suspect or what other diagnosis which we usually make with these patients?
Yeah, so I'll just come to my differential diagnosis. I thought just to maintain the continuity of flow, let me just present. So these are her hemograms, and in the hemograms, if you could note that WBC, it's right in the middle. It's normal, but hemoglobin is low at 8.7. And subsequently, at a 2 days interval time, it is 7.3, further worsened up. Creatinine is normal, 0.3. And the serial electrolytes were done for this patient, but at presentation, serum sodium is 148 and serum potassium is 3.8. So these values are important, and I'll tell the importance in subsequent slides. And the flow of the electrolytes represents the course that the patient experienced. So as you can experience with the treatment, as you can see, during the course of treatment, potassium is dipping, sodium is getting normalized. That is what is expected. With electrolytes, normally with sodium and potassium, for patients with DKA, I generally do calcium, phosphorus, which is low in this case, and magnesium. These are sometimes required because lots of electrolyte disturbance do occur in a case with diabetic ketoacidosis. Pain, abdomen, and vomiting were there. The LFTs were done, and as you can see, it is completely normal. The liver functions are normal. So one question which Dr. Keswani raised, pain, abdomen, vomiting, of course, liver is high on the cards, and that needs to be done. But for this case, LFT is normal. Importantly, because there was a high blood sugar right at the admission, we had done glycosylated hemoglobin, which is 11.8, clear elevation. And because it's a new case, the patient was treatment naive, suspected to have type 1 diabetes. It is essential to document what is the secretory capacity of the pancreas. So C-peptide was also done in the same emergency sample. And as you can see, C-peptide is low in this patient. Because type 1 diabetes, we know, is an autoimmune disease, usually associated with other autoimmune, particularly endocrine dysfunction. So a thyroid function was ordered, and it showed a low FT4. For benefit of everyone, I would like to say that FT4 in our hospital, the range is 10 to 28. So slightly low, but TSH is still normal. And the antibodies, the anti-thyroid peroxidase antibody, were quite significantly high in titers. The other autoimmune disease that is coexistent in large prevalence is the celiac disease. And with in every type 1 diabetic patients, I generally tend to do TTG as a screen for celiac disease. But in this patient, it is normal. There's no elevation of the tissue transglutaminase. And as you can see, the urine examination, this is not the complete report, but important things are mentioned in it. Urine glucose of 1000, urine ketones are 150. That's the highest that can be measured in the dipstick. So the subsequent report of the urine, you can see that ketones have become negative as an effect of treatment. Glucose has also gone down. So after the ICU admission, the patient, because of the diagnosis, because of clinical dehydration, the first thing was to do was fluid resuscitation. And because of high diabetes, regular insulin through IV syringe pump was initiated. And I'll be discussing how we give in subsequent slides. And when ketones are relatively lessened up, switched over from IV to subcutaneous insulin injection. Prophylactically, we give parenteral antibiotics because in some cases, one of the precipitants of ketoacidosis is infection, and I'll come to this. However, in our patient, as you could have noted, there was no fever, there was no leukocytosis, and urine examination and chest x-rays were normal. So just on day 2, we stopped the parenteral antibiotics, and just before the discharge, because the patient is newly diagnosed, particularly type 1, we provide the diabetes-related education, not just for this admission, but also for preventing future occurrences of diabetic ketoacidosis. And I generally I order the antibody panel for type 1 diabetes wherever the suspicion is quite high. So in our hospital, we do not do the GAD antibodies, and these were sent outsourced. But these antibodies, they returned before the patient was discharged in very high titers. And as you can see, with the institution of the treatment, acidosis improved from baseline of pH of 6.94 to 7.48, and bicarbs that were undetectable became normal to 24.6. Ketone, there were ketonemia, and as I mentioned, right at diagnosis, it was 4.2, and before discharge, it was 0.6, and you'd already seen that ketonuria also resolved. Blood sugar normalized, and there was marked symptomatic improvement in the sense that fatigability was not there. There was no pain abdomen. There was no vomiting. The patient had started eating. And we discharged the patient on multiple subcutaneous insulin regimen of Lispro and Degludec with a small dose of thyroxine because antibodies were positive. There was a goiter and a hematinic because the patient was anemic. And the final diagnosis with which the patient took, therefore, is that she is type 1 diabetes, type 1A to be precise. She's newly diagnosed. She's got associated thyroiditis, and she was admitted with ketoacidosis, which was moderate to severe intensity, and the precipitant is that it presented right at diagnosis. So with this phase, with the background of this case, I would just like to review the literature on diabetic ketoacidosis. So the 3 most common emergencies in diabetology are diabetic ketoacidosis, the hyperosmolar hyperglycemic state, and hypoglycemia. So out of which DKA and hyperosmolar hyperglycemic state is one of the most common and most severe metabolic complications of diabetes mellitus. And with the passage of time, there are now well-developed diagnostic criteria, treatment protocols by most professional societies, so that protocols are there in place. In fact, there are protocols for pediatric patients as well. And these protocols have been pasted in the emergency for easy reference. Why it is important is because diabetic ketoacidosis entails a high mortality. When I was a resident, literature had mentioned that mortality reaching up to 25 to 30%. But the recent reviews have revealed that with the institution of adequate treatment after protocols, the mortality has gone down considerably, and it's less than 1% in high-end centers, those who are well-versed. But mortality is still high and remains a challenge in vulnerable age group, particularly those with elderly patients and those who have other comorbid conditions. Hyperosmolar state, although does not have ketosis, but hyperglycemia is more severe than diabetic ketoacidosis, and mortality is even higher in the hyperosmolar state. And there was this question regarding the differential diagnosis, and this slide tells you the diagnosis and the differential diagnosis of diabetic ketoacidosis. So there are three terms, three metabolic derangement occurring simultaneously in a single patient. So hyperglycemia, commonly we see in our OPD as diabetes mellitus, various forms of diabetes mellitus, type 2 being most common, type 1, but most of them are compensated in the sense that ketones are not present. And sometimes even the emergency state of hyperosmolar hyperglycemia is there without ketones, but it should raise a red flag when sugars more than 500 are suspected or detected, particularly in type 2 individuals, elderly group, who are markedly dehydrated. And of course, some patients have glucose intolerance, particularly the SIBs of type 2 diabetes patients can have this. And there is lots of stress hyperglycemia, and we had witnessed lots of stress hyperglycemia in the COVID era, not only because of the COVID, but because of the steroids. But these patients did not land into ketosis. And the second aspect of this clinical condition is ketosis. So ketosis can occur because of starvation, because of alcohol, and these are the two most common causes. But if ketones are associated with hyperglycemia, then this is hyperglycemic ketosis, and this should raise a red flag. And the last condition is the increased anion gap acidosis that occurs in diabetic ketoacidosis, and the increased anion acidosis usually occurs very commonly because of lactic acidosis in hypoxemic patients, or hyperchloremic acidosis, uremic acidosis. These are all causes of raised anion gap acidosis, and because of presence of lactic acid or salicylates or uremic toxins that we see acidosis. But the acidosis that is usually seen in diabetic ketoacidosis is because of the ketone bodies, acetoacetic acid and acetone. And when all of these are present in a single patient, this forms the diagnosis of diabetic ketoacidosis. So the diagnostic criteria for DKA are ketosis more than 3 millimoles, or significant, that is at least moderate ketonuria on urine stick tests. Although if you read the American Diabetes Association's protocols or AACE guidelines, they have rejected the use of ketonuria as a criteria, and there's more reliability on blood ketones and ketonemia rather than ketonuria as a diagnostic criteria. Blood glucose, of course, anything more than 300, that is about 10 millimoles, either because in a known patient of diabetes or wherever we encounter blood glucose more than 300, it should raise the bell. And I already mentioned about acidosis, which means the blood pH is less than 7.3, and bicarb level, because it's a metabolic acidosis, less than 15 millimoles. So these are the diagnostic criteria for diagnosing a patient with DKA. So in our patient, ketonemia was 4.2, higher than 3. The ketonuria was severe, one large ketonuria, 150. Blood glucose was 413, very high. And bicarbs were undetectable, if you could have seen that slides, and pH was less than 6.9, clear-cut acidosis. So these forms the diagnostic criteria for this is the epidemiology of diabetic ketoacidosis. The curve A represents that because of increasing burden of diabetic patients, diabetic ketoacidosis incidence is increasing as a secular trend. But curve B is more reassuring, and it represents the mortality because of DKA. And as you can see, over the period of time, it is decreasing because of well-established treatment protocols and high intensity of monitoring and care that these patients are given. A little bit about the theory, how hyperglycemia occurs in diabetic ketoacidosis, and that's because of increased gluconeogenesis and increased glucogenolysis. Both these processes occur because of absolute insulinopenia. So just if you recollect your biochemistry, the rate-limiting steps are insulin sensitive for both gluconeogenesis and glycogenolysis. And if there is insulinopenia or absolute insulin deficiency, you are going to have increased gluconeogenesis, glucogenolysis. And just because of absence or reduction in insulin levels, there is decreased glucose utilization in the peripheral tissues. Ketones are generated because in a stressful condition, in presence of insulinopenia and increased catecholamines, there is liberation of free fatty acid, which are converted to ketone body, mainly the beta-hydroxybutyrate and acetoacetate. So these are the ketone bodies. What we measure in point of care strips is the beta-hydroxybutyric acid as the ketone bodies. But what we measure in the urine is the acetone. So acetoacetic acid, beta-hydroxybutyric acid, they contribute to the acidosis. And I would like to remind the audience that insulin has multiple actions. It not only leads to increased absorption of glucose, which all of us are familiar, even laypersons are familiar with, in the peripheral tissues, adipose tissues, muscles, but it also prevents breakdown of the fats, free fatty acid. And this action is actually a sensitive action. And that is why ketosis is more common in type 1 diabetes, where there is absolute insulin deficiency. But in type 2 diabetes mellitus, this much degree of insulin is present that prevents breakdown of fats, and ketone bodies are not generally present in type 2 diabetes mellitus because some degree of insulin is present. The glycerol helps in gluconeogenesis, which I had mentioned. And this is just a flow chart of what I have already said regarding pathogenesis and the absolute insulin deficiency in the chart on the left top, if you can see, leads to lipolysis, because as I had mentioned, this is the most insulin sensitive action. So I would like to remind that insulin, apart from glucose uptake, prevents lipolysis. It is mitogenic and it has other anabolic actions. So we all are familiar with insulin as glucose uptake, but some degree, even if it is present, will prevent lipolysis. But if there is lipolysis, it indicates near absolute absence of insulin at that particular time in the patient's body. And I'd already mentioned, because of lipolysis, there is free fatty acid flux to the liver and leads to generation of ketosis. Because of generation of ketosis, the acid buffer is overwhelmed and you have an increased anion gap acidosis, and that is the pathogenesis of diabetic ketoacidosis. So coming to the clinical aspect, what are the usual symptoms of diabetic ketoacidosis? And this table I have taken from an Indian study done about 5 or 6 years back. So in Indian patients, nausea, vomiting, pain, abdomen are present in half of the patients. Dehydration is quite marked, another half of the patients. Although it is already mentioned, it is thought that it's a coma, but in most patients, coma is not there. A slight degree of alteration in the sensorium, and even in our patient, she was just apathetic simply because of exhaustion. So altered sensorium in a quarter, and Kussmaul's breathing. We are classically, when I was a student, this Kussmaul's breathing was quite emphasized, but it's present in minority. If it is present, it's quite diagnostic. It's quite characteristic fruity odor, Kussmaul's breathing, and sometimes even without. At SMS, where I was trained, even getting ketone strips for urine, and it was the nose that made the diagnosis for diabetic ketoacidosis patients. Some patients may land in shock, and these are very critically ill patients. And this is a review slides for the precipitants of diabetic ketoacidosis. It's a busy slide, but let me tell you that in most studies, it is the infection, non-compliance, and new onset of diabetes that are the precipitants of diabetic ketoacidosis. In our country, infections are quite common. And in the study that I just quoted, pneumonia was present in about 40% of the patients, and which was followed by urinary tract infection. Pulmonary tuberculosis, all of us are quite familiar. It's what is also quite common. Here, I would like to also mention mucormycosis, although it is quite specific to the acidotic part, is there if it is there, but it is less sensitive. The prevalence is quite low, but if it is there, you can be pretty sure it's diabetic ketoacidosis, and this can happen. It's a fungal infection. We saw some of the cases during the COVID infection, even in non-diabetic patients for reasons otherwise. But if it is there, you should always look for it because it's a deadly infection, and the COVID has taught us that. Sometimes some patients can have a diabetic foot as a precipitant of diabetic ketoacidosis. It's a busy slide which compares the severity, clinical features in severe and mild cases of diabetic ketoacidosis. And rather than looking at the whole slides, I would like you to focus that the severity factors are concentrated because of acidosis. If you look at blood pH, serum bicarbonate, anion gap, and we look at the p-values between those patients who are alert and obtunded, these values are significant. So if the patient is obtunded, if the patient is severely dehydrated, probably acidosis is quite high in that patient. That would require some treatment. And we can grade the degree of or severity of diabetic ketoacidosis as mild, moderate, and severe. And this classification is also based on the acidosis, that is pH 7 point up to 7.5 is mild, but anything less than 7 is considered severe. And why it is important to grade the severity of ketoacidosis is because not only is the prognosis poorer in severe patients, but also the treatment is a little bit different. And as we will see, soda bicarb in mild patients could be detrimental. But in severe patients, it could be life-saving. Something like dexamethasone for COVID. In mild COVID, if you give dexamethasone, probably harmful. But in severe cases, it was life-saving. Quite controversial. And same applies for sodium bicarb in diabetic ketoacidosis. And these are the other parameters by which you can grade ketoacidosis. As far as lab features are concerned, if you try to look at diabetic ketoacidosis, just look at the C-peptide level, quite low. Fourth from the bottom. So C-peptides are quite low. It is important to look at C-peptide because apart from ketosis, the hyperosmolar state resembles very much like the diabetic ketoacidosis. And the difference between diabetic ketoacidosis and hyperosmolar state, apart from ketones, is the level of C-peptide. And this tells why ketosis occurs in a DKA patient and does not occur in HHS patient. And I had already mentioned that the mortality of HHS is paradoxically quite high compared to DKA patients. In our patient also, the C-peptide was low. It represents absolute insulinopenia. So, and of course, in the same slide, 3-beta hydroxybutyrate, that's the acetone, that's the ketone body, and that is also significant. So one of the differential diagnoses of DK is a hyperosmolar state. And that's why I put up this slide. Coming to the management goals. So the first and foremost goal is tissue perfusion and restoration of the circulatory volume. And if shock is present, try to revert that. That's the first step, and not the soda bicarb, and even not the insulin. Second goal is correction of electrolyte and reversal of ketosis, because these are two deadly aspects of ketoacidosis. And of course, resolution of hyperglycemia, identification of a precipitant, and avoiding complications of therapy. And last but not the least is prevention of future episodes of DKA. Sometimes when I see my own patients coming up 2 to 3 times in 2 to 3 years with DKA, just tells me that my education is not complete. And every time I may be doing, making them recover from DKA, still, if I'm unable to prevent the future episode of DKA, the job is still incomplete. And therefore, education is quite important. Coming to the fluid therapy, which is the cornerstone in management of diabetic ketoacidosis, we begin with isotonic saline. And we generally try to give as 20 ml per kilogram per hour. The rate is also important. At least 1 to 2 liters needs to be administered right in the emergency level before the patient can be shifted anywhere, either in ICU or HDU or the ward. For pediatric patients, the dose for fluid is even higher, 20 to 25 ml per kilogram, because children are more dehydrated and their body contains more proportion of water, and their fluid calculation is calculated on a 48-hour total fluid analysis. But I assume that for this discussion where we would be dealing with adults, my fluid therapy pertains to the adult patients with DKA, and we have to monitor the hemodynamic status very closely. And what to observe is electrolyte, and even if the arterial blood gas is not available, a venous blood gas is good enough, at least in diabetic ketoacidosis. And this needs to be monitored every 4 hours. And we have to avoid the complications of therapy. One of the dreaded complications of therapy is cerebral edema, more common in children and young adults. Usually it's an iatrogenic complication where fluid and electrolytes are just overzealously administered. And therefore, caution needs and constant monitoring is required so that this complication, which is iatrogenic, can be avoided. Coming to the insulin therapy, the first statement is very important. We have to give insulin therapy only if serum potassium levels are higher than 3.3 milligrams per liter. And that's because we need to give insulin only as IV. And I would like to recapitulate that insulin therapy, and I mentioned about various actions of insulin therapy. IV insulin causes shift of potassium from extracellular to intracellular levels. And if there is hypokalemia right at the start, perhaps we should first correct the potassium before giving the insulin therapy. So otherwise, the choice of insulin in DKA patients is the regular good old soluble insulin. And this needs to be given in doses of 0.1 units per kilogram as IV infusion per hour. And this needs to be monitored with blood glucose, which can be done 1 hourly, 2 hourly, based on the severity of the type 2 ketoacidosis. And why we do this is because we need to titrate the dose of insulin, and the rate at which glucose should fall is at least 50 to 60 milligram per DL per hour. That is the rate by which it should fall. So by this rate, we assume that patient's blood sugar should be dropping to at least 250 to 300 before reaching to an acceptable level. So that when the blood sugar is less than 250, we need to change the fluid from isotonic 0.9% NS to 5% half NS. These are the recommendations, and at which time we can ask the patient to eat something. If there is no pain abdomen or vomiting, still try to monitor the blood sugar 3 hourly, 4 hourly based on the severity, and try to maintain the blood sugar at 150 to 200. And that's the way to follow the patients. And a word about electrolyte correction. The insulin needs to be given as IV infusion only when, I repeat, potassium levels are more than 3.3 milliequivalents per liter. And if it is low, we need to infuse potassium as potassium chloride injection through infusion once again. And we generally give 1 ampule per liter of saline. And we need to monitor the electrolytes every 4th hourly to keep the potassium levels in between 4 to 5. I also mentioned that as part of electrolyte measurement, I do calcium, magnesium, and phosphorus. And enough studies have shown that phosphate replacement, mind you, if you recapitulate that in the patient that I just presented, phosphates were low, 0.7, but I did not replace because replacing phosphate does not alter the course of BP. However, if hypophosphatemia persists in form of weakness, perhaps phosphates could be thought of, but the diet usually supplements the phosphates that is already low. I also mentioned about soda bicarb, and it is quite controversial. Why it is controversial? Because in mild to moderate cases where pH is not, pH is above 7, giving soda bicarb is detrimental. And why it is detrimental is because the hemoglobin dissociation curve, if most of you would recollect your physiology chapters, it shifts to the left. That means less oxygen is dissociated from the hemoglobin in presence of soda bicarb, so that until the pH is less than 7, or if the bicarbonates are really low, less than 5 or so, we should defer giving soda bicarb. But for example, in our patient also, pH was less than 7, 6.9. The amount of soda bicarb is 50 millimoles of soda bicarb in 200 ml of NS, along with half ampule of KCl, because the complication of soda bicarb is hypokalemia. So in short, this is the treatment algorithm suggested by the American Diabetes Association, and there are 4 cornerstone therapies for DKA. One is the fluid management. We begin with fluid management, try to stratify the patients, mild to severe, but generally in severe cases, something like 15 to 20 ml of isotonic saline needs to be given. And when blood sugars are dropping to up to 250, in some books it's 300, try to shift over from normal saline to half strength 5% dextrose. That's the first cornerstone therapy. Second is insulin therapy. Only regular soluble insulin needs to be given through IV as IV infusion and needs to be monitored. The dose needs to be monitored based on the rate of drop of blood sugar. Potassium is quite important and need to monitor. I mentioned about that. And phosphate is more controversial. Soda bicarb is equally controversial. Suffice to say that in severe cases, try to use at least 50 millimoles of soda bicarb. A word about complications of diabetic ketoacidosis. Sometimes dehydration is quite severe and the patients can land in shock. Sometimes if they are not improving with shock, think for a myocardial infarction, myocardial event that has occurred in the patient. Venous thrombosis can occur because of dehydration. Pulmonary edema because of excessive fluid resuscitation, and cerebral edema, particularly in young adults and children, usually occurs early in the course of disease. So dear friends, I'll just stop my presentation here.
Thank you, Dr. Ajay, for nicely presenting a good case of diabetic ketoacidosis. And this is the right time we should start discussion. And I will invite Dr. Neeraj Lodha and Dr. Surendra Kumar from Bikaner for any queries, any discussions. Dr. Ajay, patients come to you with a history of the problem is many of the patients first go to the nearby physician or nearby GP with the complaint of pain abdomen or some weight loss for observed for the 15 or 20 days. And that GP usually says that, of course, it is not a common problem for those who are making general practice. Things may be different for we people. We are especially looking for more diabetic patients. So they advise for some liver tests, liver tonics, and for weight loss, some things. And afterwards, they come to you for when they are diagnosed diabetics. Of course, they come to us when they are at least diagnosed diabetes. If a patient is already diabetic, it is very easy for the attendants to understand and for us to find it out. So what is your take on this? How can we increase the chance that physician or GPs do not miss when a patient who doesn't have any previous history of diabetes develops these symptoms of pain, abdomen, or vomiting or dyspnea?
At the outset, I would like to say that one of the activities by RSSDI, if I'm not mistaken, was to include blood sugar as the fifth vital sign, which means that pain, abdomen, headache, for whatever reason the patient comes, if you can take pulse, BP, respiratory rate, and henceforth temperature, why not a blood sugar? It's available almost free of cost by the companies. So, but coming back to your question, if you still cannot do a blood sugar as point of care, pain, abdomen with vomiting, many differentials are associated, renal calculus, liver causes, to more rarer causes like acute porphyria, intestinal obstruction, quite common, appendicitis, quite common, cholelithiasis, quite common. Sometimes you can have a cerebral cause, meningitis as the cause. So you have to, for all endocrine conditions, need to have a degree of suspicion for the condition. And unless we have this suspicion, perhaps we are likely to miss if we don't have them.
Thank you, Dr. Ajay, for the very lucid presentation. I have a question regarding the ketoacidosis in type 2 patients. Since there are so many more type 2 patients, so how common it is in type 2 diabetic patients? Second, what is the euglycemic ketosis and how it is associated with SGLT2 inhibitors? And what is the prevalence in the patients who are taking this SGLT2 inhibitors and ketosis?
So first question regarding the prevalence of DKA in type 2 diabetes patients, because of the mechanism of pathogenesis, much less common in type 2 diabetes patients, something reported to be something like 3 to 5% of type 2s will have diabetic ketoacidosis compared to something like 20 to 30% of type 1s having ketoacidosis. But because of sheer volume of bulk of type 2 patients, we see more number of type 2 diabetic patients with ketoacidosis. I hope that answers. The second was regarding euglycemic ketoacidosis. Usually it came to attention after SGLT2 inhibitors. Because SGLT2 inhibitors, they flush the glucose out. That's the mechanism of action. It leads to increased counter-regulatory hormones, and therefore ketones are generated. So it usually occurs in patients with type 1 or LADA type of patients, usually occurs in those patients who are taking insulin, but because their glycemia becomes better because of use of SGLT2 inhibitor, their insulin is stopped. And once the insulin goes away, these patients land in the euglycemic ketoacidosis. So one way, one of the recommendations for SGLT2 inhibitors, because they are now widely used, even more widely used after most of them becoming off patent, is that we need to stop SGLT2 inhibitors, particularly when the patients are hospitalized for one reason or the other, or the patient is in stress, because that could lead to precipitation of euglycemic ketoacidosis.
Thank you, Doctor. May I audible, sir?
Yes, yes, audible.
Sir, thank you very much first.
But and not visible.
Yes, not visible. Thank you very much, Dr. Ajay. Very nice presentation, no questions, and then no things are left behind as far concern about the management. But during the day-to-day practice, as far concern about the ketonemia, the facility of the detection of the ketone at the every center is not possible, particularly in the villages and particularly the township. So can you tell us about and what things, suppose the such type of the facilities are not available, how can we diagnose the particularly the diabetic ketoacidosis in the severe condition?
So answering your question, there are no special requirements for diagnosing ketonemia. The glucometer that measures blood sugar can also measure blood ketones. All you need to have the ketone strips. So if you can have a glucometer, without a glucometer, blood sugar cannot be monitored and DKA cannot be monitored. The same meter is used for measuring blood ketones. As simple as that. So it is not very expensive. The blood test of ketone is not very expensive. So it's done with the glucometer right in your clinic. All you need to keep, if you are having a glucometer, you are keeping glucose strips, just keep 2 or 3 ketone strips with you. And whenever you find that blood sugars are more than 250 or 300, with the same instrument, you can measure the blood ketone as well and try to find out. The second part of your question was severity, and I would like to mention that severity is more dependent upon the acidosis. So for that, you would require a patient to be sent to an ICU or a facility. Most ICUs have the ABG machine. So in a clinic, if you intend to diagnose and treat in a clinic, that's a blunder. I think I would not mince my word. Ketoacidosis has high mortality, requires frequent monitoring, and therefore needs to be closely monitored. Even if no ICU facility is available, at least a hospital admission is warranted.
Thank you, Dr. Ajay. One question also here.
Yeah, please go ahead.
Yeah, sometimes the patient admitted inside the ward and the patient is comfortable. Blood sugar is going to be controlled. Sodium and potassium and the electrolyte condition as well as the fluid balance are within a normal limit in spite of all kind of the things. Patient has gradually deteriorated and he became unconscious. Can you tell me or tell us about something regarding this?
Yeah, so as I mentioned, one of the complications is thrombosis. So stroke could be precipitated. Cerebral edema could be one of the reasons of deterioration while on treatment. Sometimes if electrolytes, particularly the sodium level, if it is not corrected nicely, or paradoxically, overzealous correction of sodium sometimes can lead to this. So these are the two things. You should always, one of the precipitants of DKA is a stroke, and therefore, if the patient is not improving, deteriorating DKA patients, try to look for an underlying stroke, cerebral edema. Or alternatively, if there is a CNS infection as a precipitant, and I had mentioned that mucormycosis, this is also a spectrum related to rhino, mucor to cerebral. That's the completed spectrum of mucormycosis. So if the mucor that you see in the nose or the palate, if it extends to the brain, the patient, while on treatment, while on correct treatment, can still deteriorate.
Thank you, Dr.
At what stage we should decrease the insulin infusion? Any particular guidelines, or at what sugar level we can decrease this insulin infusion from 1 unit per kg per hour to 0.5 unit per kg per hour, or any new recommendation for this?
So once the ketoacidosis resolves, we should stop IV insulin. The patient, if he is eating, then try to shift over to the subcutaneous insulin. And the way to transit this is that on the previous day, the insulin requirement through IV, that would be the total dose. Give 50% as the basal insulin. Give the rest 50% as 3 times as the bolus insulin. The American Diabetes Association suggests that for type 1 patients, it should be insulin analog.
Sir, one more thing. For this euglycemic ketosis patient, what will be the fluid of choice? Whether to give the normal saline or should we give other fluid?
No, it has to be isotonic saline only.
So any risk of cerebral edema if we give a isotonic saline to the patient who has already a normal blood sugar levels?
I think if cerebral edema is there, mannitol needs to be given up and rate of IV fluid needs to be curtailed up rather than change of fluid, type of fluid. So if the glucose level is below 250, the guidelines suggest that try to shift from 0.9% to 5% dextrose with 0.45 NS. So these bottles are available in most ICUs, in most hospitals. So availability is not an issue. And depending upon the condition, try to do that.
Sir, in this case, you have discussed what was the reason for anemia and the cause of the anemia?
Nutritional. Yeah. Good point. I thought someone would catch up. Yeah, so this patient came in follow-up and she was eating and the follow-up hemoglobin was 12. This I had not shown. It was purely nutritional. The commonest cause of anemia in type 1 one should lead to think for celiac disease. It was repeated again on her. Again, it came negative. Yeah.
So the common thing is a nutritional, whether it is a mixed or any.
So this patient, no, this patient was a female patient and she had a history of menorrhagia as well. So I would suggest that nutritional with blood loss was the cause of the anemia in this patient. So, but just that educating the patient, not only about diabetes, but overall condition gives remarkable, gratifying results.
Sir, one more thing, like in your hospital with in Durlabji like that, you ordered so many investigation like TPO, TTG, IZ and all the other investigation. What at the basic level, what investigation you suggest? Because in the periphery, it's not possible to do all these kinds of investigation at one set. So any suggestion for minimum kind of investigation?
Even at my hospital, we don't do anti-GAD antibodies, need to outsource it. Depends upon the clinical suspicion and the way of practice, what you want. Whether if supposing the intention is to collect a series of type 1 patients or DKA patients and publish it, maybe perhaps you need to do a battery of tests. But if you just want a clinical improvement, maybe a more limited test, although even in if the patient is a type 1 patient and DKA patients, it is prudent to do most antibodies because at least a celiac and a TSH is something that should not be left out in a type 1 patients.
Dr. Ajay, there's a question from Dr. Vipul. Can type 2 diabetic patient with DKA, once stable, be discharged on oral antidiabetics? If not, how long should they be kept on insulin?
No, if the patient is type 2 confirmed case, if the patient was earlier on OHA and there was a precipitant leading to DKA, and we kept maybe about a week later, generally I tend to shift back to oral agents. Of course, we need to educate the patient that prevention of DKA is one of the treatment aspects that needs to be emphasized. So if you think that the patient profile is such that he is educated, motivated, and clinical profile suggests that perhaps there is enough insulin, as well OHA is justified.
Thank you, Dr. Ajay. Thank you. It was a nice presentation, and you gave a good orientation of your case, theoretical aspect of DKA, and many of the practical tips. And also, Dr. Neeraj and Surendra has also participated well for bringing many of the facts about the diabetic ketoacidosis.
Dr. Prakash,
yes.
Can we have one point?
Yes.
Because I raised this question previously also, a detection and a ketonemia. So I was conveyed that it requires a different instrument to detect ketonemia, number one. Number two, you can have dipsticks also for the ketone testing, which is very convenient and very economically done also. So two major dipstick and understanding ketonuria could be one of the good answers for that.
Sir, usually parts also ketodiastics are available, and with that we can measure every hourly, and initially for a few hours, then later on at a more interval. So that is always available. Since our PG time, multi-sticks and ketodiastics are available.
Yes. Number two, to an assessment of DKA and discharging the patient, whether to put in a basal bolus or whether to put a basal plus or whether to put in OHA. So the previous history, number one, BMI of the patient, number two, associated clinical comorbidity, number three, associated industry with thyroid disorders could be one of the ready factors to decide what could be the medication at the discharge ticket. So that could be one of the tips also. This, I have an excellent, good opinion, beautiful presentation, outstanding, beautiful, Ajay. You have done a great job. My all congratulations.
Yes. Congratulations, Ajay, Dr. Neeraj, Dr. Surendra. Thanks, Dr. Padman Sharma, for your inputs. And I hope we will continue this kind of discussions every month. And I invite Dr. G D Ramchandani to please give vote of thanks to all the dignitaries to the speaker.
Thank you, Dr. Prakash Keswani, for your kind words. And first of all, I would like to congratulate and thank the entire team of RSSDI Rajasthan chapter, especially our patron and the past chairman of RSSDI, Dr. K K Pareek sir, and the mentor also, and present chairman, Dr. Girish Mathur, for starting this wonderful CME program. And the basic theme behind this program is to reach the knowledge to the small places and rural areas. That is the main aim of this CME program. And I also would like to thank our speaker, Dr. Ajay Shah, for this wonderful presentation of the diabetic ketoacidosis, which is a very serious complication in type 1 at the time of presentation also. And I would like to add one more thing, that in the later age, after confirmation of type 1 diabetes, even later on also children have sometimes came with DK because of the lack of the education and not using the proper insulins, not using the proper blood sugar monitoring, or some physicians are using pre-mixed insulins twice in a day. There are a lot of things. I think we have not discussed there in the after once diagnosis. In future also they come recurrently, they develop DK. That also be discussed, and that is also very important point to prevention of that DK. So that is to be done by education about the insulin injection technique, monitoring, prevention of how to check the ketones and all these things. There is a different topic. I think that also very important. So thank you, Dr. Ajay, for giving the wonderful talk and in a very simple and very simplified way. And I also thank Dr. Prakash Keswani for seriously, he's the captain of this entire TME. So I think you are the Dhoni of our Rajasthan. So you are taking care of all the things in whether it is a batting, keeping, or team management. Thank you, sir, for your time, spending the time and dedication for this project. And thanks to National President Dr. B.M. Makkar sir and National Secretary Dr. Sanjay Agrawal and past President Dr. And thanks to all the delegates who attended this program. So I request all the attendees to kindly attend next program, and that we are planning to every fortnightly. I think every Thursday, every alternate Thursday.
Every second Saturday, second Thursday of every month.
So I think this was the first experience. It's also have a good experience to all of us. And next time we'll work hard to request the members of the RSDI to join more number. And thank you to all of you. And I request Dr. K K Pareek sir to final concluding words and blessings of few kind words, sir.
Excellent talk by Dr. Ajay Shah, excellent interaction, and a very good initiation by our president and Dr. Prakash Keswani. It's really a much useful program to our physicians and clinicians. So congratulations and compliment to the team RSSDI Rajasthan chapter. And I think we'll be greatly benefited with this common and a very common emergency seen in type 1 diabetes patients. Thank you very much, everybody, for attending, and good night. Thank you.
Bye-bye, sir. Thank you very much, Pareek sir.
Thank you,
Girish Mathur sir, for your inspiration for starting this program. And I hope Dr. Girish Mathur sir must be happy and satisfied.
Thank you, Prakash. We had a wonderful discussion and presentation. Thank you, Dr. Ajay Shah, and our panelists, Dr. Neeraj Lodha, Dr. Surendra, and all the delegates for attending this program. We'll be doing this every month.
Yes.
Every month we'll be doing this case-based discussion. Thank you so much for joining.
Yeah, Dr. Prakash, ये first कौन से पहले Thursday को?
Second Thursday.
Second
Thursday of every month, sir. Second Thursday of every month.
हाँ, वो क्योंकि first Thursday को अपने IECM का होता है.
Second Thursday, sir. It is second Thursday of every month.
But that's good. That's very good. Thank you. Thank you. Very good.
Bye-bye, sir. Thank you.
Thank you, sir. Thank you. मजा आ गया, sir. Thank you very much.
Thank you, sir. Thank you for giving opportunity. Thank you.
अब अगली बार से और ज्यादा लोग अटेंड करेंगे मेरे ख्याल से
50 को क्रॉस कर गया